Hello everyone. Our next topic of discussion is intrarenal AKI. And the most common cause of intrarenal AKI is acute tubular necrosis. We'll discuss this in detail. We'll discuss about important condition which can cause acute tubular necrosis, contrast-induced nephropathy, atherosclerotic disease, rhabdomyolysis. We'll discuss about acute interstitial nephritis, which can cause intrarenal AKI, chronic interstitial nephritis, discuss the etiology, feature, diagnosis. Glomerulonephritis can cause intrarenal AKI, vascular diseases, intratubular obstruction, tumor lysis syndrome, cardiorenal syndrome. So all these topics can cause intrarenal AKI. The most common cause is acute tubular necrosis. So let's start with acute tubular necrosis. The most common cause of intrinsic AKI causes about half of the cases of AKI in the hospital. So whenever you have a patient with AKI and you're suspecting acute tubular necrosis, the number one thing I look for is medications. Vancomycin, so the one in red, these are the common medication in the hospital which can cause ATN. I start with medication vancomycin, aminoglycoside, NSAID, tenofovir, cisplatin, carboplatin, and then I see if they receive any contrast in last 3 days. CT scan with contrast, they went for the cardiac cath, they receive iodine dye, so any contrast in last 3 days. And then there are certain conditions which can cause ATN too, like hemolysis, rhabdomyolysis, phosphate nephropathy is not very common these days because we don't use phosphate for bulk preparation these days. And then other causes, rare, immunoglobulin, sucrose, mannitol, dextrans, hydroethylene starch. So mannitol, it can happen in ICU if you are using mannitol for decreasing intracranial pressure. Otherwise, less common. What is the pathogenesis? So two main pathogenesis, ischemia and nephrotoxic agent. So let's say if the patient has septic shock, they will be hypotensive, blood pressure will be low, which will lead to ischemia and cause necrosis of tubular cell and cause AKI. And second thing is nephrotoxic agent like medications, which we discussed already. They damage to proximal tubule and cause injury. So it has different stages in non-oliguric phase. So non-oliguric mean they are making urine, but less urine for 1 to 3 days. If it continue to progress, patient will not make any urine or less urine for 1 to 3 weeks. And then recovery phase after 3 weeks, patient will start diuresing and produce lot of urine which was retained with improvement of BUN and creatinine. So diagnostic workup we already discussed. I showed you the chart. So you can order BNP. So urine sodium will be very high because kidney lost the concentrating ability. FeNA will be greater than 2%. Fractional station of urea will be greater than 35%. The diagnostic test is you take the urine and see it under the microscope, and it will show muddy brown granular cast exactly like this. The way you are looking at here is exactly like this. More the cast present under the microscope, more severe ATN is, and if the kidney is completely shut down, that's actually an indication to consult nephro for possible dialysis. But if the patient is in non-oliguric phase, still making some urine, then you can wait and see where things go. Next is contrast-induced nephropathy, which can cause acute tubular necrosis. So this can happen in patient who has risk factors already for kidney abnormality. They have diabetes, hypertension, chronic kidney disease, CHF, hypotensive, multiple myeloma, recently received contrast. So what happened is, so they have all these risk factors, and on the top of that, You give them contrast, which will cause renal vasoconstriction, lead to ATM. Diagnosis: history of receiving contrast in 3 days, last 3 days. FeNA will not be accurate. So what is the treatment? So the most important treatment is before and after the contrast. You'll give them fluid. How much fluid? 1 ml per kg per hour. So let's say they're 70 kg. Give them 70 cc per kg, 70 cc per hour, 6 to 12 hours before the procedure, before the contrast, and 6 to 12 hours after the contrast. Stop all the nephrotoxic agent. You can use low dose contrast. Use of prophylactic N-acetylcysteine. The mechanism is unknown and is controversial. So takeaway points: increasing serum creatinine within 3 days of contrast exposure. Fluid administration 1 ml per kg per hour, 6 to 12 hours before and after the contrast exposure. Atherosclerotic disease. So what is the risk factor? Patient has diabetes, hypertension, hyperlipidemia, smoking. What caused the disease? So let's say a patient went for the vascular procedure like cardiac cath, abdominal aortic aneurysm repair, and after the cath, patient developed kidney injury. The duration is the most important thing. So kidney injury after weeks to month after vascular procedure. So if you differentiate between contrast-induced injury and vascular injury, this happened in 2 to 3 days, and this happened weeks to month after procedure. So they will have livedo reticularis, blue toe syndrome because of emboli, blocking end arteries of the toe. Intestinal ischemia can happen, GI bleed, TIA can happen, and then rest they can have non-specific symptom, fever, headache, weight loss. Diagnosis is based on history. Vascular procedure within a month. Urine analysis, non-specific, it can have proteinuria with diabetes. Sometimes they can have hematuria. They can have eosinophilia, eosinophiliuria, hypocomplementemia during the acute phase, which reflects immunological activation at the surface of exposed atheroemboli. Skin, kidney biopsy if diagnosis remain in doubt. So you can take the biopsy from here, skin biopsy. So it's a cholesterol crystal embolization in the end arteries of the skin. Treatment, no treatment because the damage is done. Later risk modification, you can start them on statin, control blood pressure, control diabetes. So what are the takeaway points? So kidney injury develop after weeks to month after vascular procedure. No proven medical therapy for atheroembolic kidney disease.